giant cell arteritis and polymyalgia rheumatica were described back in the 1950s in a paper in the Journal of American Medical Association, the JAMA. And really, till 2016 or a few years ago, all that doctors did was when they were faced with PMR and GCA, really prescription for steroids was given, and really very little assessment was done. And essentially these conditions languished due to a lack of understanding of these conditions. And of course, a lot has changed in the last 5 years. And 2016 really is a landmark year. Can you imagine a British national organization awarding the Outstanding Best Practice Award for, to a particular unit for giant cell arteritis? And that's happened this year. So the BSR 2016 Best Practice Award has actually gone to Southend, and that's purely for the treatment of giant cell arteritis and the fast track pathway. We've had a lot of new trials coming up for the management of GCA. As you know, we are stuck with steroids, and steroids. A few years ago, PMRGCA UK did a patient survey of the top concerns of patients who suffer from this condition. And the first one was living with steroids, number 2 was coming off steroids. So it really, it puts in the limelight what are the major concerns. So back in 1990, when I was a very, very junior research fellow working at Guy's Hospital with a very eminent professor of rheumatology, Professor Gilbert. So Gabriel and I, we actually described for the very first time elevation in the blood of a particular chemical substance, a cytokine called interleukin-6. And we did it with a very laborious bioassay looking at cells, whether they respond to levels of IL-6. And this year at the American Rheumatology meeting in Washington will be the first announcement of a breakthrough in the treatment of GCA with a medication called tocilizumab. And tocilizumab works for giant cell arteritis primarily by inhibiting the effects, blocking the effects of interleukin-6 in terms of inflammation. Interleukin-6 is actually the vehicle through which blood vessels get inflamed, why we get all these constitutional symptoms. So, for example, why patients lose weight, why patients become anemic, why patients have night sweats when they develop giant cell arteritis, and it also then leads on to the damage to the blood vessels, such as the temporal arteries, such as the arteries behind the eyeball. These are called the short ciliary arteries, and that leads to inflammation, and it's the inflammation then blocks the arteries, and then we get the disasters such as sight loss. So the optic nerve, which is an extension of the brain, is actually has to have constant blood supply, otherwise it dies. It's very vulnerable, it's very delicate, it's and so the slightest ischemic damage to the optic nerve results in sight loss. And sadly, it's a form of sight loss which doesn't happen over years, which is the sort of thing that we see in diabetic retinopathy. In people with GCA, the major problem is today you can see that you've got 20/20 vision, and tomorrow one eye is gone. Completely gone, and sometimes that disaster occurs in the other eye as well if it is not picked up. So sadly, we have patients who have actually lost sight in both eyes, and one of the major targets for the management of the condition is to try and inhibit interleukin-6, and we have now we have medications which can tackle that. And tocilizumab is the first in that group of agents. And in fact, the Lancet, which is a very, very prestigious medical journal, has featured in the month of March or April trial, which comes from Switzerland, which has shown that the drug works very well for patients with GCA. And in November, we will hear the details about a large multi-center international study called GIACTA. And GIACTA will be reporting about its benefits of tocilizumab in giant cell arteritis, and we hope that, in fact, it's actually met all its endpoints, the primary and the secondary endpoints, and so we hope by next year we should have licensed new medications for the treatment of giant cell arteritis. In addition, talking about trials, we have other trials. They're at the moment in incubation, so similar medications which inhibit other inflammatory markers. And the recent last week at the EULAR, the European Rheumatology meeting, which this year was actually held in London, we had discussions about several new trials coming up. So the future is actually quite bright. So we have been very late in terms of understanding these conditions, but we're trying to make up for the lost time. And so in the next 5 years, I suspect in rheumatology, giant cell arteritis, polymyalgia rheumatica. We do have a very nice clinical trial that's coming up for the treatment of polymyalgia rheumatica as well. So we should have new medications for this condition, particularly targeting people who really don't do very well just with steroids, who have constant flares in their condition. So that's why I think that the 2016 is absolutely a landmark year. Another reason why it's a landmark year is that it's going to see the release of our new guidelines for giant cell arteritis. And we've been working very hard. Dorothy's already alluded to it. We published guidelines on PMR last year. These are international guidelines, and they've it's in public knowledge, and it's being quoted quite a lot. And this year we are working on GCA guidelines. Can I have a glass of water, please? So what are the fundamental tenets of our guidelines? Okay, so and the major aspect of our guidelines are the overarching principles. And the first overarching principle that we make in the guideline is that GCA is a medical emergency, and it should be regarded as such, it should be treated as such, it should be treated on a parity as we treat stroke, for example. And the reason why we make that statement is because we have shown at Southend, using the fast track strategy for the treatment of GCA, you can significantly reduce the burden, the complications of sight loss in GCA. What does that mean? So it means that we now know that sight loss really occurs when inflammation is untreated. So patients, particularly older patients who present with new onset giant cell arteritis, their arteries are particularly vulnerable to blockage, and therefore particularly the patients we see in the later 70s, early 80s, or even older, they sadly often present with sight loss. And because the patient herself or himself has not actually picked up on some of the non-specific symptoms, and that's where a charity like this comes in, really. For example, the early signs and symptoms of giant cell arteritis can be pretty non-specific. You can actually dismiss it as a heavy flu, and really you get aching, you get the polymyalgic symptoms, you've lost weight, and you don't feel like eating, get some night sweats, and a lot of patients feel, oh, it's an infection, and you go away. And they ignore it, and then bang, you have a ischemic complication such as sight loss. Now that not only occurs with the patients, but also when patients go to GPs with these sort of symptoms, quite understandably, the general practitioner then does blood tests, looks at why the patient has been unwell. And of course, the commoner causes of feeling like this is infection or something, a common serious condition such as cancer. So patients who become anemic, then the general practitioner will try and institute the investigations to look for these commoner conditions. And again, GCA goes untreated. And we have shown that particularly the sight loss aspect of GCA is negatively associated with headaches. So, you know, over the years, GCA has been associated just with headaches. And therefore, doctors and patients feel that if you don't have a headache, you don't have GCA. That's not true. And so, although GCA mainly presents with headaches, but the patients we see with sight loss are often people without headaches. And so we have a challenge on our hands to try and educate our patients, to try and educate professionals that GCA can occur without headaches. And we are trying to do that. We've just recently had a review accepted where we have proposed a new classification, new diagnostic method for GCA, which includes polymyalgia. So one of the important things is we have thought that polymyalgia and giant cell arteritis are different conditions. They're not. They're actually part of a spectrum of diseases. And in fact, a lot of patients with GCA will present with polymyalgia. And so there is a challenge. We need to distinguish between polymyalgia itself versus the polymyalgic symptoms of GCA. And it may be very difficult. So these guidelines are actually stating very, very clearly that the condition of GCA is an indication for urgent specialist referral. It is not for a general practitioner to diagnose, treat and manage. So the fast track pathway, essentially what it says is that you, when the general practitioner is faced with a patient with symptoms which are suggestive of GCA, more than low probability, then the GP starts steroids, 40 to 60 milligram prednisolone, and refers the patient as an urgent fast-track clinic in the hospital. And that's where they get their specialist assessment. And so we have a very set way of assessing our patients. You'd be very pleased that the BSR has taken it on board that education for GCA needs to be trotted out to rheumatologists. So in July, the month of July, Southend is hosting the BSR Traveling Fellowship, where we have lots of trainee rheumatologists as well as young consultants who are actually coming to Southend for a whole week to be taught about how we assess patients with GCA. So what we do then in the fast track clinic is then we assess our patients very carefully, and we do what we think is now a major investigation. We do an ultrasound. We do an ultrasound, so many of you may have had ultrasound of different parts of your body, and ultrasound has been there for the diagnosis of abdominal symptoms, diagnosis of other pelvic problems, etc. But ultrasound only recently we have started using in the diagnosis of inflamed arteries. And you can put a ultrasound probe on the inflamed temporal artery there, and in patients who have got inflammation, you can actually see what's called a halo. So you have the blood flowing through the artery, and then the whole arterial wall, which has got swollen with inflammation, you see as what we call dark areas, and it's that dark halo that is surrounding the blood flowing through the artery, which is really characteristic of GCA. So, and the big advantage of ultrasound is it's non-invasive, it is available in the clinic, and we can do it, and we can actually show it to our patient. So, one big advantage of ultrasound is patient education. So, I often have my patients who I'm looking at, they actually look at the screen, and I show them, look, this is where the abnormality is. This is in your temporal artery. This is in your branches. So we need to treat it just right, so that what is happening in this artery is not replicated in the arteries at the back of the eye. And so we do a temporal artery ultrasound. If the ultrasound is strongly positive, then we don't nowadays go on to a biopsy. But often, if the ultrasound is inconclusive and we still have suspicions about the GCA as a diagnosis, we then do a temporal artery biopsy. And we start the patient on our patients on 60 milligrams, 40 to 60 milligrams prednisolone, and then we get them back in about 2 weeks, and then we reassess them in the light of the biopsy results, in the light of response to steroids, and so forth. So that's one of our overarching principles, the fast track, the clinic, the fast track strategy, and you'll be very pleased that 29th of June, I don't know whether some of you can make it, the BSR is organizing a central commissioning workshop, which is going to be attended by GPs, commissioners, NHS England, and people who actually are involved in commissioning of these services. And I'm talking about the fast track approach, and I'm actually demonstrating, it fills me with a lot of trepidation, demonstrating ultrasound in an auditorium full of about 500, 600 people. So I need to get it right, of course, but I've had a bit of practice. So that's why 2016 is really quite a landmark year. And we then also have in our guidelines, in the overarching principles, that patients should have a basic number of tests, because giant cell arteritis is not always very clear-cut. It's sometimes, there are other serious conditions of the head and neck which can look like GCA, and which are just as serious as GCA. So we need to do these other scans and other tests to exclude, say, head and neck tumors or infections, etc., to exclude these other conditions. One important aspect of the guideline is that we now know that giant cell arteritis can be associated with what's called a large vessel vasculitis, which affects the main artery in the body, that's called the aorta, and also these, particularly in the upper limbs, the subclavian arteries, the carotid arteries, the axillary arteries, and that's called large vessel vasculitis. So we've got in the guidelines, that we need to, in some cases particularly, we need to start thinking about imaging these arteries. So GCA is now in our thinking coming down into two different types of GCA. One is cranial GCA, which is presents with headaches and head and neck symptoms, and then what we call large vessel GCA. So which can present with polymyalgia, which can have involvement of other arteries apart from the cranial arteries. So these guidelines actually recognize that. We also have put in the guidelines that GCA or PMR occurs in the older person, and one of the features of this condition is that it occurs in the presence of what we call comorbidities. So many of our patients have diabetes, many of our patients have hypertension, many of our patients have heart failure, many of our patients have got chest complaints, many of our patients have got kidney problems. So, and many of our patients are very osteoporotic. They've had previous fractures. So it is very important. There is no one size that fits all. So we have to take into account the age of the patient, how well they are from the other aspects, whether they have all these other comorbidities, what medications they are on. So that all assessment has to be made before, while we are developing an individualized management plan for the patient. And we say that that management plan must be articulated in a specialist clinic. really it needs that sort of expertise. And certainly our GPs are coming to agree with us that giant cell arteritis, particularly in the initial stage, should be managed by a specialist. And then you can have shared care. So once you have a plan, once the patient is better, then we can have some agreed shared care for these patients. So that's all in our basic guidelines. We also have in the overarching principles aspects of patient education and self-management. And particularly because even now steroids are a major, they're still the mainstay of treatment. And what do? They have side effects. So we need to try and cancel out many of these potential side effects in patients with GCA. So, and one important effect it has is on the muscles. And it's called myopathy, and steroids have a major effect on muscles. They lead to early deconditioning. And therefore, many of our patients, actually, even when we have treated their GCA, actually are very unwell because the steroids have made them very myopathic and taken away many of the energy aspects of the patient. So, individualized exercise program to try and tackle some of these steroid side effects are very important. And we need to pay attention to osteoporosis, gastric protection, etc., etc. So that's all in the guidelines. So I've really covered quite a wide aspect of the management of GCA that we are seeing at the moment. We are also making major advances in terms of actually in PMR as well. We've started in PMR, we've had the classification criteria which have been published, and we've shown that ultrasound is very good for PMR as well. So it picks up the inflamed arteries, the bursitis there. And we are now starting doing biopsies of these bursae to try and find out what is the etiology of PMR. So we are making progress. We're trying to join these two conditions up, and certainly we are making major progress in all these areas. I think at this stage I might stop here, and very happy to answer any questions.